So the talk's open for a few minutes of discussion. Do any of the panelists have a question for Jeff?
Jeff, what's your anticipated duration of effect? Because we know that with other gene therapies that there is some wearing off of the effect over time.
Yeah, it's certainly hard to say. We haven't seen any reduction in protein levels in cohort 3 at 18 months. We have patients in that cohort who are out almost at 2 years with no retreatment. We've certainly seen from other gene therapy trials as well that some patients are able to go multiple years. So it remains to be seen, but it's encouraging.
I have a question. The patient that required multiple retreatments, did that correlate with their protein level by any chance?
That patient also had a high protein level and still required multiple injections.
Jeff, when you look back at the serum neutralizing antibodies, do you think that affected response at all?
We haven't seen any correlation with response in serum antibodies. And obviously, with subretinal delivery, you hope to obviate the need to worry about neutralizing antibodies.
When you think about designing your phase 2b study, what thoughts do you have about what types of patients you're going to want to enroll moving forward?
So I still like the idea of demonstrating a positive anti-VEGF response. We took some patients who met the response level, but it was relatively minimal. So for instance, there's a patient of mine who was in it who had a very small response, but it met the level, and that patient didn't respond to the gene therapy and hasn't responded to multiple anti-VEGF therapies. So I think I'd want to have a more definitive response before enrolling them.
I had a question, Jeff. I mean, seeing low inflammation, we've seen other trials which have more inflammation. Can you comment? Is it the AAV8? Is it the subretinal? Do you think it's the location? It's the viral vector? Why does this have less inflammation?
Well, subretinal delivery may help with that. Certainly, neutralizing antibodies wouldn't be a factor with that. AAV8 has a lower rate of neutralizing antibodies in the general population than, say, AAV2. But the thought is that the subretinal delivery can help with that matter.
Jeff, there's still a relatively small number of patients in the world who've had subretinal injections for gene therapy. Why don't you share with us the learning curve or the challenges for the surgeons in these cases and for those of us who may be one day wanting to do it ourselves?
So I think caution and care is really the most critical component of this. So we spent almost 2 years in preparation for this, standardizing the approach, working on it in the lab, hand-selecting the surgeons to do this, looking at the videos after every case to learn pearls and pitfalls from every surgeon on how to do that. And I think that's the approach that you need. We learn from every one of these, and so how to approach it. Some of these go remarkably straightforward, and others require multiple attempts to get the blebs to form. But I think we learn from every one of these, and sharing those experiences is pretty critical.
And presumably one of the concerns with the area that needs to be treated is less significant with AMD.
Wiley, you had a question?
Do you want to comment on the need for immunosuppression?
We haven't needed it here. In other studies, they're employing it.
Okay, and you're comfortable?
Well, we haven't seen the need for it here, and that's subretinal delivery. I'm involved in multiple other gene therapy approaches, and I'm also comfortable with using it, whether it's topical or systemic in those. What I've seen is it's relatively limited.
Great. Thank you very much.